Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Greetings and thanks for joining us for this second of 4 clinical clips. My name is Babafemi Taiwo, I'm the Chief of Infectious Diseases at the Northwestern Feinberg School of Medicine. Today we'll cover 4 interesting topics that were discussed, or presentations that were discussed. And the first one is from the HPTN 084 data analysis. And the question here was really to understand the impact of delayed dosing of cabotegravir on drug levels. This study, you would recall, showed superiority of long-acting cabotegravir to TDF-FTC. They defined 2 kinds of delayed injections. In the first kind of delayed injection were patients who had their second injection 8 to 14 weeks after the first one instead of 4 weeks. And the second kind of delayed injections were injections that occurred subsequently that were anywhere from 12 to 18 weeks after the last dose. And in terms of what the results showed, there were a couple of interesting or important findings. One was that when injection was delayed by around 6 weeks or so, the plasma levels of cabotegravir still met the pre-specified level, which was at least four times the protein-adjusted IC90, which actually was achieved in 98% of participants. And also another measure, which is levels of at least 8 times the protein-adjusted IC90 was achieved in 87%. So really, a lot of patients had high levels of the drug, adequate levels of the drugs, even when they had injections delayed by around 6 weeks. What that might mean clinically is, can we be dosing this medication even less frequently than every 2 months? For example, can it be given every 3 months? They provided some insight on that question, specifically saying for men, this is not something that should be considered because the levels in men tended to be lower over time compared to women. In women, the use of this intervention every 3 months, it's still up in the air, but at least the evidence that they showed suggested that it would not be a crazy idea for studies to be done to ask the question whether it can be dosed every 3 months in women, but not in men. Another study described was again from the HPTN group, and they described a new syndrome called Levi syndrome. And if you recall, there were a few individuals or participants in the HPTN studies that became infected with HIV despite receiving on-time injection of cabotegravir. For example, in the HPTN 083 study, there were 6 individuals who had this new infection. And the investigators reported on the presentation of these individuals and compared it to presentation of individuals who we know of the syndrome that we have typically associated with HIV infection, the acute HIV retroviral syndrome. And a number of differences were identified, which include the fact that Levi syndrome tends to be associated with very low levels of HIV at the time of infection, which means that the assay that we typically use to confirm HIV may be initially negative, and that sometimes it takes months for the antibody to become positive. There may be no symptoms whatsoever in patients who acquire infection while receiving long-acting cabotegravir compared to persons who have it with a typical HIV infection who tend to have a lot of symptoms in many cases. And also, on the good side, transmission is felt to be very unlikely in persons who have the Levi syndrome because the virus level is very low. But again, the false positive or false negative results that can occur in this Levi context is something that we have to all keep in mind as clinicians. And of course, drug resistance is another thing that can occur in the context of Levi syndrome, but not in the context of usual HIV infection. So these are things that clinicians will have to keep in mind as we expand the use of long-acting cabotegravir for HIV infection, for prevention of HIV infection. A third study explored the impact of integrase inhibitors on cardiovascular disease. This study came on the heels of the RESPOND trial, which was published in Lancet a few months ago, showing that, suggesting that integrase inhibitors may be associated with an increased incidence of cardiovascular disease, particularly in the first 2 years after exposure. And this left many people scratching their heads as to the potential cause. And a number of people suggested that maybe there were biases that were not controlled for in the RESPOND trial that led to this unexpected result. And so the Swiss cohort study that was presented today was very important in that it asked the same question but used a different approach. It followed individuals for a median of 4.9 years and showed that although in the initial analysis, it appeared as if integrase inhibitors once again will be associated with higher risk of cardiovascular disease. But in fact, when they corrected for a variety of imbalances, they found no increased risk with integrase inhibitors, which really should come as somewhat of a relief. And again, we need to understand this better, but this finding contrasts those of the initial RESPOND trial that raised some concern. And the final study I will talk about is one that came from the Ward 86 clinic at UCSF, in which they used the cabotegravir-rilpivirine long-acting combination in a population that really has been difficult to treat. So the study had some unique features in that it actually used only the Q4-week dosing of cabotegravir-rilpivirine, and wraparound services that were quite robust were constructed around each of the participants to support adherence, and they were required to at least express a willingness to come to the clinic every 4 weeks. What did the study show? It actually identified, I'll just focus on the individuals who were viremic at the time of the injection. A total of 57 individuals fell in this category. And of the 57 individuals, 55 of them have maintained biologic suppression through a median of 26 weeks of follow-up. There are 2 individuals who had early biologic failure, and those individuals will have to be followed up. And we look forward to learning more about this really important intervention. There's a lot of excitement about this potential study, a potential treatment approach. A lot of questions also remain, but at least it has opened a door that I hope that with careful investigation over time, we'll be able to optimize to get the best benefit for our patients. So we should all stay tuned to learn more about where and how this might be used in our challenging patients who are unable to take anything orally. So thanks for joining us for this second episode of 4 clinical clips. Please go to the landing page where you'll be able to access the slides and also view previous clinical clips. And I look forward to seeing you for the next 2 clips in the coming days.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.